Hello, I'm Matthew Einstock, Managing Editor for Modern Healthcare. Thanks for tuning in to the latest edition of the Checkup. Successful rollout of the coronavirus vaccine is going to take a highly coordinated approach, not just between providers, drug makers, and the government, but also within health systems. And with operations in 21 states, CommonSpirit Health certainly has a unique vantage point. Joining me today is Dr. Thomas McGinn. He's the recently appointed Executive Vice President of the Physician Enterprise at CommonSpirit, and that includes 5,800 employed providers, more than 1,000 ambulatory sites, and 21 value-based organizations. Prior to joining CommonSpirit, he was a Physician-in-Chief and Senior Vice President of Physician Network Operations at Northwell Health in New York. Tom, thank you so much for being with us. We know it's an extremely busy time.
Great. No, happy to be here, Matthew, and thanks for having me.
So as I said, you're new to CommonSpirit. You're about a month, 5 weeks into the role. Obviously a very exciting, but also very stressful time. Just what's the first few weeks been like for you in this transition from Northwell, which is fairly regionally based, to now a national health system?
Yeah, I mean, it's been fascinating for me. As you just said, I went from a regional operational unit to a national one in 21 states. So I think, understanding each market and some of the regulatory issues is a big, challenge. Each state has its own, local state regulations and cultures that you really need to figure out. So I've been on a culture tour the last few weeks.
So I guess part of that, as we think about that that prospect, the vaccine rollout, one area I do want to talk to you about, we don't really have much of a national strategy in terms of it. They left a lot of it to the states. So as you look at that rollout, 21 states that CommonSpirit operates in, what's that process been like for CommonSpirit? And have you been able to glean some best practices from one state to another, from one region to another?
Yeah, it's been interesting. Look, there are challenges, as I've mentioned, in some of the states' regulatory issues, and everyone is different to some extent. I mean, there are similarities and themes that play out through each state, and we have developed and organized ourselves through divisions, and we have strong leadership that works with local administration and local policy folks, but then we always meet and talk at the divisional level every day. At a national level, we have all our division leaders coming together, talking about all those things that you just mentioned. Where can we have best practices, and where can we learn how to do things? I mean, early on, so you're constantly going from, okay, what's the local issue? What are the local challenges? And how do we help on a national level with strategies that we can drive down and also hear up from them? I mean, things like refrigeration. So we all know this vaccine needed an amazing refrigerator, not one that you have in your house. And I think from a national level, to have the procurement expertise to purchase and deploy these freezers way ahead of time was something where the national level we could really help out. And so you play that out through a lot of different things during the whole pandemic, whether it was PPE, purchasing the refrigerators. And then you have to go and figure out at the local level, okay, so we can't distribute the vaccines from this. We don't go to this person to get the vaccine. We have to go to this county official. And that's where you kind of get into some of those nuance.
And as you in your role, you're also looking at the physician enterprise, right? So as I said at the outset, about 5,800 doctors. How do you start queuing that staff up to be vaccinated, and are they some of the ones that are first in line for CommonSpirit?
It's a really important question. I think there's a mistake here to think that the ultimate frontline providers are in a hospital only. We have to remember over 80%, close to 90% of all COVID patients are managed outside the four walls of a hospital. Some of those are young kids, like my daughter had COVID, she did fine. But some of them are pretty sick and are managed in our respiratory clinics and other areas. So they were in the first line to get vaccinated. So first thing here is we got to make sure all of our providers, our nurses, our respiratory techs outside of the four walls of the hospital are getting vaccinated. Okay, so that is a major first step for us. The next step is then preparing those offices as we come with the new vaccines that don't need the deep refrigeration and can be distributed through our offices. How are we going to prepare those offices for for patients and communication with all our communities?
Is there a difference too, Tom, between dealing with employed docs and those who may be affiliated with the organization, and how you handle that prospect?
Well, there's certainly a difference, but we are communicating and working with all of our physicians, whether they're in, a CIN or an IPA or they're employed with us. There may be some subtle differences in, purchasing for them versus purchasing for the employed, but we are trying to keep this all one big integrated network and working together with them. So I think that's one of the strengths that we bring to the table is we can organize ourselves together and not try to break into different camps, and that's been working very well. Everybody's working very closely together.
Yeah, it's interesting, as you said a couple of seconds ago, that so much of the treatment or a lot of treatment is happening outside of the four walls of the hospital, and I think we hear so much about those patients in the ICU or in critical care beds, and we don't always think about them post hospital and how their care is being managed and what that entails.
It's not even post hospital. Remember what I said, 80% of patients never go into the hospital. During the beginning of the pandemic, I was personally managing 30 patients on my cell phone who honestly, had they showed up at a hospital, wouldn't have been admitted, but they had care at home, they had the ability to do that. So we have two big groups of people. We have those that never came into a hospital, and within that group were people that were pretty sick. They may have been in bed for 3 or 4 weeks, but never went into a hospital. And then we have people discharged from the hospital, and those are across the United States, thousands and thousands and thousands of patients who we're helping care for, oxygen, medication. Some, percent have, what people have called long haul syndrome, where, foggy brain and other problems. So all of that, and we're training ourselves up to become experts at that and to help our patients. And it's sort of the story not told, on the front lines.
Well, I'd imagine part of that too is the debate that we're having nationally about the vaccine just itself, right? So we have the traditional anti-vax movement, which has been around for quite a while, and then the politicalization of the current vaccine process. So what role do you think the CommonSpirit physicians are going to play in just being able to communicate to the public about the efficacy of these vaccines that, have been given emergency use, but seemingly are safe,
So it's a huge role. I mean, if you look at various data sets, and there's been a lot of different publications about how people think about this. And I think, let's put aside it's the actively anti-vax group. Okay, let's put those aside. Let's assume those are 10%. But there's about 50% of the population that's ready to go. I think they're going to get their vaccines, and that number is getting bigger and bigger and bigger, because I think as the pandemic has gotten worse and more people have been touched by the pandemic and the reality has hit them, they're going to be more eager to take this vaccine. The people that are not sure are the ones that are going to go to their primary care docs, and they're going to talk to them about that. And that's a very powerful role on a national level. That not just primary care, any doctor. I mean, I get calls almost every day. Are you going to take the vaccine? I'm like, yes, I'm going to take the vaccine. So we play a major role in pushing that 50% all the way up as high as we can. And I know we can do it. I know we're going to do it. I think patients are going to line up for this, but they're probably going to call their doctor. And that's a huge responsibility. And we're training our physicians. We're educating them how to talk to their patients. I mean, they're smart. They know what they're doing. They understand these vaccines. And we're publicly showing them taking the shot, which is really important. Why? Your doctor's taking the shot. You should take the shot.
But as if we compare it to the flu vaccine, it's not universally, people aren't universally getting the flu vaccine shot. We're talking about that year over year over year. Is there any parallel? Are there any lessons learned from the messaging around flu to this, or is it completely different?
No, there's a lot of similarities to the flu vaccine. It's been a major. Look, I'm a primary care doc. It's what I do. You know,
Right.
I give flu shots, I give Pneumovax, and it's been a lifelong crusade of mine to get people to take the flu shot. And it's one of the simplest things that saves the most amount of lives across the country. I think that it's in some ways we're in a better position than we are with the flu shot because the reality of the COVID crisis, the reality. I mean, if you think about the number of people, I mean, I don't know, Matt, about you, but I can name, 10 people that have been sick with COVID, and a couple of them deathly ill. Colleagues, I lost a colleague to COVID, a good friend, a doctor who died of COVID. So I think that reality is so fresh, and people are going to be a little more attuned to taking that vaccine for that reason. Where in the flu shot, maybe, I had a cold last year after they gave me the flu shot, it's okay. I'm like, oh, don't get me started. Don't get me started.
Right. I want to pivot a little bit, although still probably factors in here. I know one of the areas that you're passionate about is data collection on social determinants. What are some of the lessons that you've learned or we've seen over from COVID, the civil unrest over the summer, on the importance of data collection on social determinants, but also the importance of putting that data into actual use? And how do you think you're going to be able to do some of that at CommonSpirit?
Yeah, it's been eye-opening and across the country. I think, look, to be honest with you, one of the reasons I'm here at CommonSpirit is because CommonSpirit's roots, right there, CommonSpirit goes into the neighborhoods people don't go into. So the foundations of CommonSpirit is serving our communities, and many of the communities that have been left out in the, really what is an arms race of health systems. So it is at the core of who we are. And I love being in the room and having conversations with leadership here because it is front and center in almost every conversation that we have. And if you look at the rollout of the vaccine and you look at it, is literally if it's not the number one thing being discussed, it's the number two thing. Okay, how are we going to get to communities, whether it's our rural communities, we serve the Dakotas, right? And some really, those are, communities that are in tremendous need. You look at the vaccination rates in some of those communities, just talk about the flu,
Right.
I mean, terribly low. So I would say, we're genetically made up to think about this. I think there's a lot we could do better. I think we're collecting our data. We're looking at this. And we're attacking it as a real primary mission of ours.
Do you have one or two things that, as you look across maybe even the value-based care organizations that you'll be leading, that you want to start to implement right away?
In terms of, structural
social determinants,
social determinants of health. Well, I think that, some of the issues around availability of urgent care are something that I really want to take a closer look at, because I think, you might see some little pockets where you don't have enough of that. And that's become such part of the fabric of healthcare these days, right? I mean, we take it for granted, but it's relatively new. So that's something that we're looking at. And I think, the access to testing is something, that we need to be very cognizant of. And we want to make sure that we have that no barriers to testing or vaccination, zero barriers. It just should happen fluidly. And where are we set up in some of the most difficult to reach communities? And that's not difficult to reach, not a distance per se, right? It could be around the corner, but there's no infrastructure there. And where is our blind spots in that testing and vaccination space that we might be not seeing?
Okay. One other area that I kind of want to pivot to, as you look at the physician enterprise that you'll be leading, and obviously this predates you, but during the investors call with analysts and investors in October, CommonSpirit leaders talked about how some of the productivity gains that the physician enterprise was seeing were disrupted. I think was their use, disrupted by COVID, which obviously CommonSpirit's not alone in that matter. COVID disrupted the entire industry.
Yes, it did.
As you think about the physician enterprise and whether it's those physician groups, ambulatory care centers, or the value-based organizations, are there one or two areas where you think you need to, pivot the groups to get back on track, or do you have to wait till we get out of COVID entirely to be able to start to, get back some of those gains?
Well, I'll say a couple of things. One is we're back. So I think that's the news flash. It's amazing. We're back to pre-pandemic numbers, and I'm really satisfied with those numbers. And I think what happened was we figured it out a little bit while the pandemic was happening. We figured out how to create a safe environment for our patients and our providers and our nurses to come in and see patients. And we certainly saw, the side effect of a pandemic is not always the pandemic. It's the things that
Right.
don't happen, right? It's the preventive care. It's the vaccines, the pneumavax and the flu shots, and children not getting vaccinated. So in addition to being back up where we think we should be on a volume, of course, we could always do a little better. We're looking very closely at some of the high payoff screening things that may have dropped off. How many people love getting a colonoscopy? How many times does it take? I've canceled mine recently. It's like the one thing you're always going to cancel. And you finally get up the guts and you're going to get, no pun intended, and you're going to go for your colonoscopy in the pandemic and they cancel it. We want to make sure that person comes back, right? And that's sometimes very difficult to do. So we're focused on all of those sort of preventive things that we missed and making sure that everybody knows it's safe to come back to see your doctor.
Right.
And it's worked, actually.
Great. Tom, listen, we appreciate your time. As I said at the beginning, we know it's very busy, obviously, with the vaccines rolling out. You're 5 weeks into the job, but we appreciate you taking some time to talk to us. Would love to stay in touch and check back in maybe in a few months to see how things are going then.
Yeah, I'd love to talk. Very exciting times.
Great. Thank you so much.
All right. Thanks, Matthew. Thanks for having me.
Sure. And I'm Matthew Weinstock with Modern Healthcare. We won't have a checkup on December 28th, but we'll be back with you on January 4th. Thanks, and have a safe holiday season, everyone.